So I have one disclosure. In terms of the objectives for today, by the end of the talk, it's my hope that you'll be able to describe a basic overview of circadian physiology and pathology, be able to discuss some of the emerging literature on the relationship between circadian rhythm disorders and circadian misalignment more broadly and mental health, and know how to apply basic interventions to improve circadian health. And this talk ended up being quite timely because we're going to be falling back from daylight savings this Sunday. So these are just a few headlines from the articles that are written every year about this topic. And they highlight what the sleep community has known for quite some time, which is that the switch to and from daylight savings is something that really disrupts the body's circadian rhythm. And consequently, every year it increases the risk of cardiovascular events and accidents, and worsens mood, particularly in sensitive individuals. Looking beyond daylight savings time to the topic at hand, we also know that sleep and circadian disturbances are really the rule rather than the exception across psychiatric disorders. And so I'm hopefully going to make the case for you today that sleep and circadian rhythms are one of the lowest hanging fruits that we have to improve mental health, because they are ubiquitous but also intervenable. And I think that we can do more with existing mental health treatments to target these factors. So circadian rhythms, what are they? Circadian rhythms are biological rhythms that almost all organisms, from single-celled organisms up to humans, have, and that follow a roughly 24-hour period. They're inherently free-running in complete absence of any external cues, which means that they're innate and self-sustaining, but they're entrained by a set of cues or Zeitgebers, which means timekeepers, that help to set it to the environment. So this would be light as the most potent Zeitgeber, as well as physical and social activity and feeding patterns, for example. So there are some important circadian terms to understand, particularly for this talk, but if you want to be literate in the circadian literature. So if we look at this visual, on the x-axis we have time, and on the y-axis is really any physiologic variable. And the period length, or tau, is the duration of one cycle of the rhythm. So in most people, this is actually closer to about 24.2 hours, but can differ longer or shorter depending on the individual. The amplitude is a measure of the strength or robustness of the rhythm and is around half the distance from the minimum to the maximum. And then the mesor is the average of the rhythm over 24 hours. And phase is something that we'll talk a lot about today. It refers to the timing of a specific point in the rhythm. So it could be the peak, nadir, midpoint, in relation to some other reference point or average. So the circadian timing system is conceptualized as having three distinct components. We have a central circadian oscillator that's located in the suprachiasmatic nucleus, or the SCN, of the hypothalamus, which is pictured here. Then we have input pathways for light and other stimuli that synchronize this central clock to the environment, and this is really what we manipulate clinically to influence the central clock. And then we also have output pathways that regulate the daily expressions of a range of behavior and physiology, from body temperature to hormones to attention. And we know that the SCN is the central pacemaker because if you lesion it, it abolishes all rhythmicity in behavioral and endocrine variables. So these circadian outputs are usually thought of as end results of the circadian rhythm, but in reality, many of these outputs feed back into the system and modulate the central clock itself. So for example, melatonin is both an output and a modulator of the circadian rhythm. And we also know that certain inputs can directly affect biological rhythms without affecting the central clock. So this is what we call masking the rhythm. An example would be core body temperature rhythm, which is an output of the central clock, but if you exercise vigorously, it can affect that output separate from SCN signals. And when this is all working well, the feedback process really makes the system more adaptive and resilient, helping it to maintain synchrony in response to either environmental or internal changes. So because we can't measure the SEN directly, we estimate its functioning by measuring the downstream physiologic and behavioral outputs. So most commonly, this is going to be melatonin secretion by the pineal gland and core body temperature, but occasionally you'll see cortisol or physical activity as a marker. For the average human, core body temperature peaks in the late afternoon or evening and reaches its nadir, or core body temperature minimum, in the early morning. So sleep is initiated on the downward slope of this rhythm and ends about 2 to 4 hours following the temperature nadir. Whereas with melatonin secretion, this increases soon after the onset of darkness. So this is the so-called dim light melatonin onset, peaks in the middle of the night and then gradually falls. And sleep occurs when melatonin levels are high, with onset typically around 2 hours after secretion starts, and wakefulness coexists with low plasma levels. And so these are two markers that I'm going to talk about a lot in this presentation because they are ubiquitous in circadian science. So if you hear me talking about DILMO, that's dim light melatonin onset, and the core body temperature nadir we refer to as CBT min. And then in addition to the central clock, peripheral circadian clocks are found in nearly every tissue and organ of the body, liver, heart, lungs, kidneys, even skin. And like the central clock, they do operate on a roughly 24-hour period, but they don't keep time independently as accurately as the central clock, and so they do rely on signals from the SEN to stay in sync. However, the peripheral clocks are also entrainable by non-photic cues like feeding and fasting cycles. So a pretty well-studied example of this at this point is the liver. The SEN will communicate to the liver through sympathetic nerves, glucocorticoids, other endocrine outputs, but the liver is also entrained separately by food intake. And so if this feeding is mistimed, for example, if you're eating at night in a shift worker, the liver clock will shift out of sync with the SEN to deleterious effect, like impaired glucose tolerance, impaired lipid metabolism, etc. And then whether it's in the SEN or other cells throughout the body, this is all driven by a set of core clock genes. BMAL1, clock, 3-per or period genes, and 2 cry or cryptochrome genes. So what happens is, in the cytoplasm, clock and BMAL1 proteins bind together to form a complex that enters the nucleus, binds to DNA sites, and activates transcription of PER and cry genes. PER and cry proteins are then made in the cytoplasm and accumulate over a few hours. As their levels rise, they form PER-cry complexes that then enter the nucleus and inhibit clock BMAL1. So they turn off their own gene expression and create a negative feedback loop that halts PER and cry production. Over time, PER and cry proteins are then broken down by enzymes like CK1, and once degraded, the inhibition of clock BMAL1 lifts and the cycle starts over. And how quickly these proteins get produced and degraded in the cytoplasm determines your circadian period, or tau, and consequently whether you're more of a night person, a morning person, or somebody with a typical rhythm. So night owls, or those who have a delayed circadian phase, actually demonstrate a longer endogenous circadian period, and they have mutations specifically in PER3 and cry1, whereas morning types, or people who have advanced phases, have a shortened endogenous phase with mutations specifically in the CK1 binding region of PER2. So that results in hyperphosphorylation of the PER2 protein and shortens this whole feedback loop. So delayed phase and advanced phase, those are just two examples of circadian rhythm disorders that are diagnosed when there's an alteration of the endogenous circadian system or a misalignment between the endogenous rhythm and the sleep-wake schedule that's required by the physical environment or the social or work timetable. And this ends up resulting in insomnia when the person wants to be sleeping, or difficulties with alertness when they want to sustain wakefulness. So this is a schema or a schematic of the typical biological night in gray and how the different circadian rhythm disorders vary from that baseline. So an endogenous rhythm that occurs several hours earlier, as I mentioned, is characteristic of advanced sleep-wake phase disorder. And so we actually see that dim light melatonin onset and core body temperature minimum are shifted several hours early relative to the typical rhythm. The prevalence is around 1%, and these are really not the patients that we tend to see in clinic because our society tends to cater towards the early bird. An endogenous rhythm that occurs several hours later is characteristic of delayed sleep-wake phase. So these are folks who have a hard time falling asleep and feel very energetic until 2, 3, 4 in the morning. And it's very difficult for them to wake up before 10, 11, even 12 because alertness hasn't started to ramp up until that point. The prevalence is also around 1% in general, but up to 8% of adolescents. And we do also see a physical delay in DILMO and CBT men. And these patients are disproportionately represented in clinic because of the nature of their sleep problem relative to the way society functions, right? They're often very sleep deprived and have highly variable sleep-wake schedules depending on when they can wake up versus when they have to wake up. A non-24-hour rhythm is characterized by a progressive phase delay day by day. So this is actually quite common in blind individuals, but rare in sighted individuals, although it has been observed in schizophrenia and in rapid cycling bipolar disorder. And then irregular sleep-wake disorder is typified by 3 or more episodes of sleep that occur at random, erratic times over the 24-hour day. Prevalence of this disorder is unknown. It's thought to be pretty rare, but might be more common in the context of neuropsychiatric disorders like dementia. And so these two are a little bit different from advanced and delayed phase in that there's a problem with circadian entrainment or a failure of entrainment. So either because of lack of Zeitgebers, as in blindness, or possibly damage to the SCN, as in irregular sleep-wake type. But these 4 together are called the intrinsic circadian rhythm disorders because there is an internal biological clock problem. And then jet lag and shift work disorder show sleep episodes at a variety of times, not within the normal biological night, but because of external factors. And the prevalence of shift work disorder is unfortunately very common at around 25 to 30% of shift workers, and up to 70% of frequent travelers will report jet lag disorder symptoms. An important point that I want to make here is that while circadian rhythm disorders are important to understand and diagnose, circadian disruption or misalignment more broadly that doesn't necessarily meet criteria for a disorder and may be more temporary is still quite problematic. And it's something that has absolutely become more prevalent in our society due to increase in light pollution, access to screens, more accessible travel, et cetera. And one particularly common form of circadian misalignment that I want to highlight is called social jet lag, which is essentially the difference between sleep on weekdays versus weekends. So, for example, if a night owl has an early work start time, there's a mismatch between their internal rhythm and the environment until the weekend when they can sleep as late as they want, and so the variability increases. And some studies estimate that as much as 70% of students and working adults experience at least 1 hour of social jet lag per week. Around 50% experience 2 hours or more, which is quite significant. So just putting this together so far, we have the environment, light and dark cycle, social work schedules, behaviors like feeding and activity. And these can be misaligned not only with each other, but with our internal clocks in various tissues of the body. and that causes circadian disruption. And it increases the risk for a number of physical and mental health disorders. So this is a table from a 2022 systematic review summarizing circadian issues in psychiatric disorders. And if you were to kind of read all the way through, you would see that several disorders show abnormalities in circadian clock regulating genes, in the timing and concentration. Sorry, there's a Teams alert. In the timing and concentration of melatonin and cortisol, a high prevalence of circadian misalignment, and a very high prevalence of delayed sleep-wake phase. In fact, the rate of delayed sleep phase disorder is substantially higher than you would see in a sleep clinic. So for example, there's a prevalence of around 20 to 30% in those with schizophrenia, and in some studies up to 80% of those with ADHD. Whereas some Mendelian randomization studies indicate that genes associated with an advanced phase are associated with lower risk of developing certain disorders like depression. So some circadian abnormalities are definitely common and potentially causal, although it is a bidirectional relationship. In addition, severity of misalignment, propensity towards being more of a night owl, and reduced amplitude of circadian rhythms have all been shown to predict onset and severity of mental health symptoms. So these graphs are from one of the earliest studies that was conducted in the 80s that showed that lower amplitude of melatonin and core body temperature correlated with higher depression symptom severity. We also now know that circadian variables can predict response to certain treatments. So for example, in patients with bipolar disorder, if they have more irregular circadian rhythms, if they have delayed phase, or more pronounced rhythm instability, they are likely to have a poorer response to lithium. And so this is by no means an exhaustive list of the research, but my hope to give you a sense of how circadian disruption is emerging as an important therapeutic target for helping to prevent or treat psychiatric disorders. With respect to assessment, there's still a fairly large disconnect between the assessment of circadian variables accomplished through time-intensive and fairly strict laboratory protocols and the capabilities that we have in the clinical setting, although I do think in the next few years with advances in technology that will change. But for right now, the best way to get unmasked data is in laboratory protocols like the constant routine or forced desynchronization, where the environment really is tightly controlled. So that the timing and intensity of light, participants' activity, and even their posture throughout the day, timing and amount of meals, they're either kept completely constant or manipulated to force the person's rhythm out of sync with the 24-hour day. So they require really an immense amount of resources and time. Slightly more practical alternatives that are used in research studies include collecting biomarkers in a lab visit or sometimes in the home environment, but when it's not controlled, this does increase the risk of masking effects. The current gold standard is sampling melatonin in either plasma, saliva, or its major metabolite in urine. And sampling needs to happen typically every 30 minutes, anywhere from a few hours to up to 40 hours, depending on whether you want to capture dim light melatonin onset or offset, midpoint, etc. So in the clinic setting, we do not have that time, but we need to estimate circadian parameters to effectively time our interventions. And so a common alternative method that we use is actigraphy, which estimates circadian parameters by measuring movement using a wrist-worn device. And it's a fairly reliable proxy and is valuable because it obtains data over longer periods of time. So this is an example of a patient who has non-24-hour rhythm disorder and who is clearly cycling around the clock day by day. We also use self-report measures of patients' preference for sleep timing and their perception of optimal performance and alertness. We do a detailed clinical assessment of sleep patterns and timing, often dating back to childhood, and then supplement with 7 to 14 days of sleep diaries to help us estimate circadian parameters, particularly phase. Okay, so for the remaining time, I want to focus on interventions to improve circadian health and functioning. And the focus of treatment is really primarily on improving the synchronization of the patient's sleep-wake timing and their circadian phase. And that includes the goal of reducing variability in sleep-wake timing and in exposure to Zeitgebers in order to increase circadian amplitude and improve daytime functioning. And this may and often does involve helping patients to actually shift their biological rhythms to better align with the external demands of life. So if, for example, a night owl has to be at work at 8 and they can't shift that schedule, then we shift their internal rhythm or phase advance it to better match that schedule. In terms of treatment components, intervention involves strategic receipt and or avoidance of bright light and appropriately timed and dosed melatonin, as well as behavioral strategies to improve the timing and the regularity of sleep and wake and other activities that help to entrain the central and peripheral clocks. The timing of these interventions relative to the person's endogenous clock is what determines whether there's going to be a resultant phase advance or phase delay, and this is expressed graphically here in the phase response curve. And timing really is crucial because wrong timing can actually worsen phase misalignment. So we do have to have a fairly accurate idea of what the person's endogenous phase is. So here, the x-axis is circadian time, not clock on the wall time. And the core body temperature minimum is roughly where you would see the inflection point in the middle of sleep. And then the y-axis is the degree of either phase advance or phase delay. And what you can see, if I can turn on my little pointer, is that in the evening and early night before the core body temperature minimum, if you apply light there, then it will actually shift the entire phase later, whereas light during the second half of the night and the early morning will shift the whole phase earlier, with bright light being more effective for phase shifting than dim light. So this is where we would want to be applying light to have a night owl shift their internal rhythm earlier. With melatonin, it's the opposite, so taking it in the afternoon or early evening. So the first is as a hypnotic, where when you take it at higher doses shortly before bed, it has a mild soporific effect. Most studies show a decrease in sleep onset latency of like between 7 and 12 minutes, which is very small. Although it can be more impactful in older adults who we know have a decrease in endogenous melatonin production. But the other purpose is as a chronobiotic, and there is strong support for it as such, particularly for entraining blind individuals with non-24-hour disorder, but we're going to talk more today about how it impacts delayed phase. Okay, so like light, timing of administration also matters. So this is a study of 22 patients with delayed phase who were given melatonin anywhere from 0.3 to 3 milligrams, ranging from 1.5 to 6.5 hours prior to dim light melatonin onset. And from this figure, you can see that the earlier it was given, the greater the magnitude of effect. So if it was given 2 hours prior to DILMO, phase advances were about an hour. Taken between 5 and 7 hours before DILMO, phase advances were more than 2.5 hours. So it appears that taking it earlier is better. But the previous study had analyzed the phase shifting effect with 2 doses of melatonin combined. And what Helen Burgess and colleagues have shown since then is that timing dependent on dose really matters. So here you can see 2 phase response curves for melatonin at doses of 0.5, which is the solid line, and 3 milligrams higher dose, which is the dashed line. And for the 0.5, the maximum phase advance occurred when melatonin was taken 2 to 4 hours prior to dim light melatonin onset. And for the 3 milligram dose, the peak advance occurred about 2 hours later relative to that dose. And given that higher doses do have a greater likelihood of causing morning grogginess, patients might experience strange or unpleasant dreams, In clinical practice, the lower dose seems to be the sweet spot, given anywhere, again, from 2 to 4 hours prior to what you estimate their DILMO to be. Just one additional study I wanted to highlight are results from a meta-analysis of 5 RCTs comparing melatonin to placebo and those with delayed phase. Most did administer a higher dose, around 5 milligrams of melatonin, anywhere from a fixed time of 8 to 10 p.m. to 5 hours before DILMO. And as expected, we did see an advance in dim light melatonin onset by about 1.5 hours. But what I wanted to highlight is that even though it wasn't statistically significant, wake-up time advanced by almost an hour, sleep onset latency decreased by over 30 minutes, and total sleep time by around 45 minutes. And all of these are clinically significant findings and can make a real difference in terms of patients' functioning and whether they can get up for work on time. So we know that melatonin improves circadian parameters in those with a primary sleep disorder. Unfortunately, the number of well-designed trials looking at the efficacy of melatonin in psychiatric populations is too nascent to draw any firm conclusions. But these are some of the controlled studies that have been conducted to date, either with exogenous melatonin or with a melatonin agonist like Ramelteon. And there is some evidence for successfully phase advancing the endogenous rhythm or increasing the amplitude of the rhythm. Whether this translates to improvement in psychiatric symptoms is even more nascent, but at least one study in folks with ADHD in delayed phase has shown that not only did it advance melatonin onset, but reduced ADHD symptoms. So again, a fruitful area for future research. And then I'll wrap up the talk today by discussing treatments that focus on improving behavioral and social rhythms. So first and foremost, cognitive behavioral therapy for insomnia, or CBTI, is the first-line treatment, obviously, for insomnia. But the treatment principles are applied in practice to a range of sleep disorders, including circadian dysrhythmia. CBTI is a short-term multimodal therapy grounded in the science of sleep regulation, and it teaches patients skills to strengthen and regulate their own sleep systems in order to improve sleep quality, quantity, and timing. And what we know from the evidence base is that CBTI does reduce sleep timing variability, and when it's done well, it better aligns sleep behavior with the endogenous clock. We also know that CBTI often improves comorbid mental health disorders. So for example, just targeting sleep in those with depression improves depression symptoms, especially in those who have an evening or delayed chronotype. Unfortunately, measurement of circadian parameters like melatonin onset are typically not collected in RCTs of CBTI, but many studies have looked at actigraphy and suggest that there is an improvement in the amplitude, at least, of rest activity rhythms following treatment. And when it's added to a circadian intervention like light or melatonin, we can actually produce even greater shifts in the circadian phase than with an circadian intervention alone. And then lastly, based on the social Zeitgeber theory, interpersonal and social rhythms therapy was created as a treatment for bipolar disorder, but has since been applied to a range of disorders. It's an evidence-based therapy that targets various Zeitgebers. So bedtime and wake time are some, meals, social contacts, and the goal is to stabilize external timing cues that entrain the circadian system. And in clinical studies, it has been shown to produce therapeutic results that are rapid and long-lasting in terms of functioning in individuals with bipolar, and to reduce the risk of relapse. And it's implied that the mechanism for improvement is increased stability of the circadian system, but that's not something that has been directly tested as of yet. So in conclusion, disruptions in circadian timing and amplitude are very common in a wide range of psychiatric conditions, and targeting circadian health, I think, is a promising path for improving sleep and mental health outcomes. And as research deepens, understanding individual differences in circadian biology may also lead to more personalized approaches to diagnosing and treating psychiatric disorders. Thank you.
Dr. Atwood. Really interesting talk. Let me ask you about the screens issue, which is sort of plays such a big role in so many people's lives. I guess between TV screens, computer screens, and phone screens, does that issue often come up as an important aspect of intervention, and how resistant are people? How easy is it to get people to change their behavior around those things?
I would say it's probably one of the more challenging behaviors to change, that in watching TV in bed are things that people are slightly less likely to give up. But it is very important because our melatonin starts being secreted 2 hours before our body's preferred sleep time, and light from screens we know suppresses the onset of melatonin, so it can shift your whole sleep schedule later and increase difficulty with sleep onset. We're a little bit less concerned in folks who are advanced phase and who go to bed very early and wake up very early, because some evening light can actually help to correct that and shift them slightly later. But in anybody who is an evening type, it's a very important part of treatment.
Great. Thanks. Other folks have questions? Dr. Franklin.
Sorry, can you repeat?
Dr. Franklin says she often gets asked about the risks of long-term melatonin use, and do you have thoughts about potential issues?
Yeah,
there?
that's an excellent question. So usually we hear concerns about will this downregulate my own melatonin production, and there's no data to suggest that. So it's not a concern that we have. Especially at lower doses, you're not likely to experience really any side effects. As I said, the most common are going to be morning grogginess at higher doses, or in somebody who has REM sleep abnormalities, frequent nightmares, any kind of REM behavior disorder, not REM behavior disorder, sorry, but REM abnormalities, it can make that worse. But that's really the only caution.
And to reiterate, I think I heard you say that you suggest that people take their melatonin roughly 3 hours before they're going to intend to go to sleep.
Roughly, anywhere from 2 to 4 hours at a lower dose. We can shift earlier if there's a long way to go in terms of getting their circadian rhythm on an earlier schedule. If you provide it slightly earlier than 2 to 4 hours, there's more room as their rhythm starts to shift back to still be in the phase response region, if that makes sense.
Okay, thank you. Other questions? Dr. Bray.
The research is not as strong on whether or not those are useful. So I would say it's better than nothing, but try to avoid the screens altogether, if possible.
Dr. Gould, did I see your hand? No. No, not Dr. Gould. Go ahead. Dr. Callow.
Yes, actually, that's a really good question. In the time allotted, it's hard to fit in everything that affects circadian rhythms, but exercise can have as strong a phase-shifting effect as light, because it increases the core body temperature rhythm, and that has such a strong impact on our central clock. So yeah, we tend to caution people not to exercise vigorously and get their core body temperature up too close to bed, because it can also phase shift them later. But for a night owl, somebody who struggles in the morning, it will ramp up alertness. So it's a hard sell for someone who already has trouble getting up to then go right into physical activity. But if they are able to, that's something that can help to reset their rhythm to make waking up easier over time.
So you advise people who are having trouble getting to sleep at night, you advise them not to exercise at night?
Correct.
Interesting. Okay. Seeing no more questions, and given that we're out of time, I'll thank you very much for a very interesting talk. Yeah?